Hello, my colleagues, my friends from Malaysia. I'm Renato. I'm speaking from Brazil, and this is such a great honor for me to be here, join you in this meeting, this online meeting. I know that maybe to be live, to be in Malaysia will be the best choice, but just because of the pandemic, we need to go through this online kind of communication. And this is such a great pleasure for me to be here. I'm an otolaryngologist. I have a fellowship in the United States at Harvard Medical School in otology and neurotology. And today we're going to talk about a couple tests that we call VVOR and VOR-S. So let me share my screen with you guys. Here it is. Okay, I hope you guys are seeing my screen, and we're gonna go through this talk. And we're gonna go, talking about a couple tests that we call VVOR, which is basically visually enhancing VOR testing, and the VOR-S, which is VOR suppression test, and how these both tests can help us in patients with vestibular hypofunctionings, even unilateral hypofunctions like in vestibular neuritis, or even in cases of bilateral vestibular hypofunctionings. This is my disclosure. I have a few disclosures. I work as a paid speaker for a few pharmaceutical companies around the world, and I'm a shareholder of GSK, and I got some free devices for beta testing for natus and interacoustics. To talk about VVOR and VOR-S, we need to go back a little bit and talk about the clinical head impulse test. I mean, the head impulse test is being described for the first time back in 1988 by Professor Halmagyi and Courtois from Sydney, in Australia. And this test, maybe it's one of the most important bedside tests ever to evaluate these patients. I use it to tell my medical residents in my hospital that if the general otolaryngology, if you learn how to perform a good positional test like a Dix-Hallpike test, and you know how to perform an Epley maneuver or a Simon maneuver or a Zuma maneuver for lateral canal, and if you know how to perform a very good clinical head impulse test, this is it. I mean, you are actually ready to go through these patients. And it's funny to thinking about that, because the head impulse test is being described more than 30 years ago. And right now, I mean, the last 10 years, 15 years, it's just become big. So everybody starts to talking about that. Everybody starts to be worried how to learn and to do head impulse. And it's not a new test. I mean, it's been described more than 30 years ago. And it's been described by these two guys here, Professor Ian Courtois and Michael Halmagyi. I'm such a great fan of the guys. So every time we meet them, I take pictures. I really like both them. They are marvelous clinicians and research, and they give us so many good things in the vestibular medicine. Um, about the commercial devices that we have, available worldwide, there are many different brands, but I believe that the most common ones are the IC-CAN from Interacoustics, which is this one here, this device. And another one is the ICS Impulse from formerly Autometrics, and right now is Natus. It's an American company. And what I'm going to talk today, the VVOR and the VOR-S, it was actually an effort of a group, our research group. Here's the picture of my colleagues, my fellows, and we published that back in the Cerebellum journal in August 2019. It was actually our publication that gave us the basis for what I'm going to talk to you today. And this research has been awarded by the last Fundación Interamericana de Neurotologia, and we got an award for the best research back in 2018. And we have to remember that we need to remember a few things about the eye movements, right? Before we go to the VVOR. Eye movements, we just move our eyes with basically the necessity to keep the target, steady state over my retina and especially my fovea, which what is the area in my retina that it got more sharpness of the image. So we have different strategies to move the eyes. We have different eye movements. According to Professor David Disease book, we have 6 different kinds of eye movements. We got the fixation, which is the ability to, just fix my eyes on target. It's a kind of eye movement. We got the VOR, vestibular-ocular reflex. We have saccades. We have smooth pursuit, vergency, and optokinetics. Actually, optokinetic is a combination of 2 different eye movements, which is smooth pursuit and saccade. Smooth pursuit and saccade. So this is optokinetics. And all these 6 different eye movements, there is just one which is actually related to the vestibular labyrinth, which is basically the VOR. I mean, VOR is the only eye movement that originate in the vestibular organ. Like all the other eye movements, they are, related to the central nervous system, especially the brainstem and cerebellum. And there are just 2 eye movements which are actually voluntary. And those eye movements are basically saccades and vergency. All the others eye movements are reflective. Even smooth pursuit. I mean, you cannot perform a pursuit without a target. If you try to do a pursuit without a target, you actually do saccades. So that's the reason. The saccades and vergency are only 2 eye movements that are voluntary. So, and why is important for us, like clinicians, like these specialists, why is important to study eye movement? Is because the eye movement is the best way to differentiate between a central pathology, like a stroke, and a peripheral vestibular disease, like something that affected your labyrinth, like, neuritis or, Meniere disease or any other kind of vestibular disease. So we need to understand eye movements to help us to differentiate that. And the good news is that most parts of the central dizziness, they are followed by central eye movement findings, which is actually good, because if you understand how is the eye findings for central pathology, it will make your job much more easy. So what about the cerebellum? Cerebellum is like a maestro. Its work as controlling and give you us precision for different kinds of eye movements. And we have a few structures in cerebellum that we call vestibular cerebellum, who are structures related to this eye movement control. And those structures are actually the flocculus and paraflocculus and nodulus and uvula. Right? And if you have a lesion in each of this part, you probably got a finding in your eye movement examination. For example, if you have a lesion in flocculus, you will have a smooth pursuit deficit, you have impaired VOR suppression, gaze evoking nystagmus, maybe a downbeat in nystagmus, a rebound nystagmus. If you have a lesion in your vermis, cerebellum vermis, you will affect your saccades. You will have probably a hypometric saccades. If you got a lesion in your fastigial nucleus, you will probably have a hypermetric saccades. And if you have a lesion in your nodulus, you will affect you maybe have some central position on nystagmus. You may have a periodic alternating nystagmus, and also some compromising of the velocity storage mechanism. So those are most common eye findings in cerebellum pathology. And to understand the VVOR, I want to go back in time a little bit. So this is a very old paper. It's been published in 1979, so it's more than 4 years ago. It was actually published by Professor Halmagyi from Australia. And the funny part is because in 1979, if we think about the world, we were just split in a Cold War between Soviet Union and the United States. And my colleague, my professor, my mentor, Professor Zumimai from Brazil, he was actually a aircraft pilot in Brazilian Air Force. At that time, he was flying in F-4 aircraft, and Professor Homagi was writing papers. So this is a funny part of the story. And when we come from this paper in 79, Professor Homagi already described us what is the VVOR. So I highlight here, and I want to read just to make it very clear. If, for example, a subject views a stationary target, okay, a stationary target, and if you move your head like that, not so fast, but you still see the target and move your head, and you are actually using two different kind of eye movements. You are using your VOR, your vestibular-ocular reflex, because you move your head, but also you will have some pursuit, some smooth pursuit mechanism, because you are not moving so fast. If you do like an impulse, you will isolate the VOR. But if you are moving like in a slow frequency, you are using a combination of two different eye movements, which is VOR and smooth pursuit. And this is actually what we call VVOR, visually enhancing VOR. By the other side, if we are looking at target and this target is moving and my head is moving with the target, so I'm canceling the VOR. And to cancel the VOR, I got a normal vestibular function, so my VOR tries to move my eyes like that. So to cancel this VOR, I need to do small saccades, a micro saccades that we are not be able to see with a naked eye. So this is what we call VOR-S, so VOR suppression test. Okay, just to train, pay attention to this video here. Look at this video. What this patient is doing, look at that. He's with a stationary head and the eyes are moving like that. So what eye movement is that? This is a smooth pursuit, right? Okay, a very classic smooth pursuit. What about this second video here down? So the target is fixating, but I'm moving my head, not so fast. So what kind of eye movement he's doing? He's doing VOR because he's moving the head, he's stimulating hemicircular canals, but also smooth pursuit, right? So he's doing two different eye movements here. And this is a kind of plot that I expected when I performed the VVOR test. So let's go very slow here to make clear to everybody understand. Imagine this patient's moving the head to his right side. So if he's moving the head to the right side, I got a head position, which is this yellow line. So it's moving to the right. And right now, the target, it's over here. So if I move my head to the right, I have a normal VOR that pushes my eyes to the target, and I have a normal pursuit that also keeps my eyes on the target, right? When I move my head to the left, same thing happened. So I move my head to the left, and I got a normal VOR and a normal pursuit pushing my eyes to the right, to the other side. I move my head to the left, my eyes goes to the right. I move my head to the right, my eyes go to the left. And I'm using a couple eye movements, different eye movements to do that. So actually, the head position is exactly the opposite of the eye position. So the head position to the right, eye position to the left. But in terms of comparison, the device, the optometric device, they just flip the plot just to make much more easy this comparison. So actually the head positions here, the eye positions here, and they just flip the eye position and put the green line and the other line just one over the other one to make the comparison much more easy. So this is what the device does for us. And what about the suppression? What about the VOR suppression? Pay attention. This is myself. I'm sitting here. I'm moving my head like that with a stationary target. So I'm using the VOR and pursuit. Okay. So right now, I will put a target in front of me. I'm fixating the target and moving my hand. So the target is stop and I'm moving my hand. So I'm canceling the VOR. So my eyes, if you pay attention here, it seems that are steady, but actually they are not. I mean, when I move my hand, my eyes tends to go this way and I have to cancel that. So I do microsaccades. And these microsaccades, my naked eye sometimes cannot see that. But when you have a high resolution, a high rate camera, you may see that. This is the camera that we use for head impulse test. So what happened in VVOR suppression? Pay attention here. The eyes are, look at that. I'm canceling the VOR. So my eyes are doing something like that. So I need to cancel doing microsaccades to cancel the VOR. So this is the VOR suppression, right? And to understand that, imagine that I move my head to the right and the target moves with my head. So I have a normal VOR. So my VOR will tries to push my eyes to the left side. And the pursuit will cancel this VOR and push my eye to the target. So I will do these microsaccades. Same thing for the left side. And here is the plot for a normal patient. Pay attention to that. Look at that. The yellow line is the head. So the head is moving to the left. The eyes are canceling. So the eyes are moving, are staying like in a stationary. But to keep my eyes in that position, I need to do some microsaccades. So when I move my head to the left, I do microsaccades to the right. When I move my head to the right, I do microsaccades to the left. When I move to the left, I do microsaccades to the right. So this is a normal patient. This is a plot for a normal patient with VOR suppression. I know that sometimes it seems confusing, it seems complicated, but it's not. And I'm gonna show to you examples and it will make it much more easy to understand that. Look at that. Look, the saccades are to the right when I move my head to the left, and when I move my head to the left, the saccades, when I move to the right, the saccades go to the left. Okay, so I tell you that the VOR is related to the vestibular functioning, and this move pursuit is related to the cerebellum function. So if I have a VVOR test, and this test tests two different eye movements, VOR, which is related to the labyrinth, and pursuit, which is related to the cerebellum. So I really expected that patients who have compromise in both systems, like someone who have a cerebellum lesion and also a vestibular lesion, this patient will affect the VVOR. And the classical example for that is patient with CANVAS. CANVAS is an acronym for cerebellum ataxia, neuropathy, and vestibular reflexive syndrome. And so CANVAS patients, they are probably have a VVOR, disturbance, right? This is the classical example. But our group was actually curious to understand what I'm going to expect in VVOR and VORS in patients with only vestibular disease, like patients with unilateral and bilateral vestibular loss, but with normal cerebellum. So I maybe this VVOR test would be affected. So that's exactly what we're going to see. And I'm going to represent that showing three different cases. The first case is a case of right side vestibular hypofunction. So it's a unilateral lesion affecting the right side. So let's see the case. It's a 15-year-old female. She is a student, and she had a severe acute vertigo attack 4 days ago, and the vertigo were lasting for many hours, but she's still feeling sick after 4 days. And she reported nausea, vomiting, and she got no hearing symptoms. I mean, no hearing loss. And she was at the hospital. She was hospitalized for 3 days, and he was discharged by the hospital with some labyrinthitis diagnosis. And of course, this diagnosis is wrong because she does not have hearing loss. And it's very common around the world. We got a misdiagnosing, especially with vestibular pathology. So this is the girl. And we have to remember this is the 4th day after the acute attack. Look at that. She got She got a spontaneous nystagmus with the eyes open. If you see that, look at that. When she looks to the right, the eyes okay. And when she looks to the left, which is the component of the fast phase of nystagmus, she have left beating spontaneous nystagmus, even with the eyes open 4 days after the attack, right? So here, if we suppress the VOR, suppressing the nystagmus, the visual fixation, you see that she got with the eyes open, she got a left beating spontaneous nystagmus. When I shut her eyes, the nystagmus will increase, which is very typical for peripheral cases. Look at that, nystagmus increase, and it's beating to the left, very clear. So it tells me that she got a right side vestibular hyperfunctioning, right? This is the video head impulse. Pay attention. Left side is okay, anterior canal, lateral canal, posterior canal, all 3 canals in the left side seems okay. But the right side, she got a low VOR gain in the anterior canal, in the lateral canal, but the posterior canal is fine. So this is a very typical case of superior vestibular neuritis, which is affecting the superior branch of the vestibular nerve, okay? Pay attention in the VVOR. Here is the message. Look at that. Let's go slow here. She got a right side damage, right side, okay? So when she moves her head to the right, which is the affected side, she got no VOR. VOR is affected. So if I move my head to the right and there's no VOR to push my eyes to the left, my eyes will not go to the left. So if the target is moving with my head, I will have no VOR, no saccades. So I move the head to the right, no saccades, right? I mean, no VOR, I move my head to the right, no VOR push my eye here. So my eyes follow the target. When I move my head to the left, which is the normal side, I do have a VOR in the left. So my eyes will tend to go to the other side, and I must have a saccade to cancel this VOR. And these saccades are beating exactly to the right side. Okay, okay. So this is a plot that we expect for normal patients. And here, look at it, sorry. This is a plot for normal patients, and this is a plot with, right side vestibular damage. So you have saccades to the left side, okay. What about the suppression here? Suppression is different because you're moving your head and you're, just remember, VVOR, the target is stationary. So I move my head. She got a right side damage, I move the right, there's no VOR, so I need to move to pursue the saccade to the left. So this is the VVOR. And the VOR-S, the target is moving with my head. So if I have a lesion in the right side, I move my head to the right. There's no saccades to push, there's no VOR to push my eyes to the left. So I do not need to do saccades here, right? And when I move to the left side, right, which is normal, and the VOR pushes my eyes to the right, I need to do a saccade to the left. And here is the saccade to the left side. Okay, I know sometimes seems complicated. Let's see another case. This is another case with left side vestibular hyperfunction, left side. So he was 61 years old male, truck driver. He had an acute severe attack 5 days ago, nausea, vomiting, no hearing symptoms at all. He was admitted in the ER. He got a labyrinthitis diagnosis. He was referred to an ENT specialist, and the ENT specialist said it was BPV and referred to a physical therapist, and the patient ends up in my clinic. Here's the patient. Look at that. With the eyes shut, he got spontaneous right beating spontaneous nystagmus. So it's beating to the right. So it probably tells us that the lesion is in the left side. Okay. Right now you see when he looks to the right, which is the component of the fast phase of the nystagmus increase. And when he looks to the left, the nystagmus disappear. So it's very classic in Alexander laws in peripheral vestibular cases. Here's the clinical head impulse. You look to the right, it's okay. When he looks to the left, oops, you see oversaccade, I'm sorry, here. Here's the IC can, lateral canal. He got a low gain in left side. And when we test all 6 different canals, we see that the right side is okay, anterior canal, lateral canal, posterior canal. And the left side, the anterior canal and the lateral canal is broke. So posterior canal is okay. So it's a very similar case from the other one. And he got superior branch, left side vestibular hypofunctioning. So look the VVOR here. He got a lesion in the left side is lesioned. So when he moves his head to the right, which is the normal side, and the target is stationary. So target is stationary, I move the head to the right, which is normal side. So I got the VVOR pushes my eyes, and I got the smooth pursuit pushing my eyes. When I move to the left, which is the affected side, I got no VOR. So my eyes will be here, and the smooth pursuit needs to perform a saccades to the right. So I got many saccades to the right and no saccades to the left. And this is the finding of the VVOR in a left side lesion. Suppression is the same thing. When I move my head to the left side, which is the affected side, so I move to the left. If there's affected, no VOR pushes here, no saccades necessary. When I move to the right, which is normal, my eyes go here, and I need to perform a saccades to the right to keep my eyes on target, which is moving with my head. So many saccades to the right. Let's see the last case, third case. This is a 75 years old female housewife. She got endocarditis back in 79, more than 40 years ago, by using garamicin, which is a vestibular toxin medication. And after this, this endocarditis treatment, she got dizzy and unstable, especially when he walks and moves her head, no other relevant medical condition. So it's a probably case of bilateral vestibular loss. And look at that. And she got a bilateral vestibular hypofunctioning, so you do not expect any nystagmus because both sides are damaged and both sides are not working, so you are not expecting any kind of nystagmus at all. And here's the video head impulse. So she got all 6 canals broke, right? And here's the SHIMP, the suppression of the head impulse, which is confirmed, the diagnosis. And look at the VVOR. She got both sides broke. So target is here. When I move my head to the right, target's here. No VOR, so I need to do a saccade to the left. When I move to the left, no VOR, I need to do a saccade to the right. So I have saccades to the right and to the left. You see here, very clear. So VVOR in bilateral vestibular loss, patients got saccades to both sides. Okay. Just to remember, this is the normal patient. So this is the result that we expect in normal patients. And this is the result in a patient with bilateral vestibular loss. And what about the suppression? Suppression, there's no VOR. So there's no VOR, there's nothing to suppress. If there's nothing to suppress, you see no saccades. Just to remember, this is a normal patient's suppression. So in a normal patient, you see saccades to both sides of suppression. In here, you see absolutely no saccades. I have another case of bilateral vestibular loss. I'm gonna go a little bit faster here. I don't wanna bore you with different cases, but it's a bilateral vestibular loss. Patient comes to me with a normal MRI, and this is the patient walk. And you see that she's walking, in a very difficult way because she got a bilateral vestibular hypofunctioning, and she walks in a very difficult way. When you perform a Romberg test over a phone, you see how hard is the patient when she shuts her eyes, she just falls. It's very complicated for her because she does not have vestibular functioning. And here's the head impulse. You see, oops, right side's damaged and left side is also damaged. And here's the video head impulse. You see both sides lateral canals broke. Here's the 6 canals are broke, and Shimp confirmed that. And look the VVOR, you got saccades to both sides, exactly like the other patient. So what is this summary of all the things I tell you? Look at that. This is the summary of the VVOR. If you have a normal patient, there's no expecting microsaccades. If you have a patient with lesion to the left side, you expect microsaccades to the right. If you have a patient with a right side lesion, you expect a microsaccades to the left. And if you have a patient with bilateral vestibular loss, you got saccades to both sides. So this is the slide you're supposed to take picture. This is a slide that summary everything I told you before. And what about the suppression in a patient with suppressing VOR? Normal patient suppressing, you got saccades to both sides. Patient with left side damage, you got saccades to the right. Patient with right side damage, you got saccades to the left. And bilateral patients, you got absolutely no microsaccades. So this is a summary for VOR-S. Okay. So I can tell you that. Pay attention. Look at that. This is a patient performing a VVOR, using VOR and smooth pursuit, normal patient, right? And I got this plot here. Here is a patient performing a clinical head impulse test. Look at that. The difference between this patient and this patient is the velocity. So when I perform in a low frequency velocity, you see a graph like that. And when I perform a high velocity, I expect a graph like that, which is a video head impulse test. Okay. So the point that I wanted to show you is that the head impulse, you test your vestibular functioning in this frequency here, which is much more fast, which is, between 2 and 3 and 5 hertz. And the VVOR, you are testing your vestibular functioning in a much more low frequency, right? And the suppression, when you do something like that, and you got this plot, and when you do this video down here, what he's doing right now? Is the shim, right? So my point is, VVOR works like the HINC, and the VOR-S works like shim in different frequencies. Okay? So, and why this data is such a relevant? Why this is relevant? This is relevant because according to the Barney Society, the bilateral vestibulopathy, the diagnostic criteria, it's being published in 2017. And according to the Barney Society, for diagnostic criteria for bilateral vestibular loss, you have like the symptoms, which is very well described, and no symptoms where the patient are sitting or lying down in bed. And according to the vestibular test, the patient must have a low gain in VHIT system, or reduced caloric response, or reduce the horizontal and angular VOR gain in rotary chair test. And this is the criteria for definite bilateral vestibular loss. And for probable bilateral vestibular loss, the patient must have the clinical symptoms, but you do not have any vestibular tests besides the clinical head impulse. Okay, so this is the difference between definite and probable bilateral vestibular loss case. But my point is, what is the villain in this vestibular test? For example, I live in Brazil. I live in a more than 2 million people city here. I have video head impulse, I have calorics, I have video nystagmography, I have all different devices in my university, in my clinic, but I do not have rotary chair. Rotary chair, it's a very, such an expensive device. I can tell you that I don't know how things are in Malaysia, but most parts of the dizzy clinics around the world, they do not have a rotary chair available. for everybody. So rotary chair is such a difficult task to have, right? And the point is, when you have like your vestibular analysis, you have the head impulse and the shimp in high frequency. You have calorics in a very low frequency. And you have the rotor chairs in this mid-range frequency analysis. But I don't have a rotor chair. So my point is, may I use the VVOR and the VOR-S to replace rotor chair in this analysis of the patient so I can test in such a high frequency, in such a low frequency, in such a mid-range frequency, instead using the rotor chair but using the VVOR? I don't know. So this is the question that I leave here to you. And what is our research question? Is exactly like that. Is it possible to replace rotor chair for the VVOR test to fulfill the bilateral vestibular loss criteria? I don't know. So the idea is, I have a patient with probable bilateral vestibular hypofunction. I have classical symptoms. I have positive clinical head impulse tests. I do the vestibular test. I fulfill the Barney criteria, so I have the definite bilateral loss. And what I did is take this patient with bilateral vestibular loss, and I performed the VVOR and VOR test, and the findings were pretty much, how can I say, reproducible. So I found the same findings in 100% of the patients. So it's pretty much reproducible. And I can tell you that VVOR, it must be just as big as video head impulse tests. And you say, well, Renato, I don't think so. I think video head impulse tests, you know, it's big. And how the VVOR can be such a big test. If you pay attention in some protocols like the HINTS, they use the head impulse with the nystagmus gaze and test of skill to differentiate between acute and acute vertigo, to differentiate between central and peripheral case, right? And what is difficult to analysis here? How many clinical head impulse tests a resident must to perform to become a specialist? I mean, if you go for the emergency room and you take a nurse with absolutely no experience and you tell the nurse, do a head impulse test, a clinical head impulse test, do you really believe that the test will be great? Probably not. Probably not, because she got no experience in performing the head impulse. So head impulse takes a while for you to train in that. Like this is a paper published a few years ago that show us ENT resident and a trainee, it takes more than 200 to 250 head impulse to become a specialist in head impulse. So it demands training for you, right? So VVOR, there's no training necessary because you just move your hand like that. So anyone can do that. It's much more easy than to do a head impulse. So I don't want to tell you that VVOR will replace the VHIT because it just tests different frequencies, of course. But I want you to think about that. I wanted to go through this talk. I wanted to read your papers. I wanted to listen your opinion because your opinion matters to me. So thank you very much to be here. It's a great honor to be with my Malaysian colleagues. And this is my personal email. If you have questions, you know, if you want to do some comment, criticism, please let me know. I'll be happy to respond to you. Okay? Thank you very much, my friends.